I'm Mark Packer. I'm in private practice in Eugene, Oregon with Doctors Fine, Hoffman, and Packer. And what I'm going to talk about, if I can get this to work, to advance the slide here, is achieving satisfaction with refractive lens surgery. So this is really my thing. What I primarily do, my core business is about refractive lens surgery. It really takes two forms. Refractive lens exchange performed for purely refractive purposes, replacing the crystalline lens with a multifocal accommodative lens, and also cataract surgery for patients who don't want to have to wear glasses after cataract surgery, again using premium IOL technology, but in the setting of cataract, in which case it's kind of a mixed procedure, part medical, part refractive. These are my financial disclosures. Most of these companies I work with are involved in some way in this area of refractive lens surgery. And refractive lens exchange is an off-label procedure in the United States. Just so you know, there's no products approved for use for refractive lens exchange. So here's the goal: sight without glasses. That's what we would like to get. And the bar is pretty high on this. We have a lot of demanding customers. In fact, starting a couple of years ago, I was approached by patients who wanted surgery on the same day, both eyes on the same day. For cataract, that doesn't make a whole lot of sense because, as you know, Medicare and private insurers will not really pay full fare for the second eye on the same day. And there's a lot of countries where there's a financial disincentive to doing same-day bilateral surgery, and the US is prime among those. However, for refractive surgery, there's no such barrier, and so for patients who are good candidates and would like to get their surgery done on the same day, I often bilateral same-day refractive lens exchange, and I presented my results at Hawaiian Eye this year. Anyway, this is well within our capability. Giving people spectacle independence is something we can do. These are the FDA results from the Technis multifocal study. I was medical monitor for this study. And as you can see here, at 4 to 6 months, 88% never wear glasses. That's the highest percentage ever achieved of spectacle independence in any FDA study. For comparison's sake, the Restore 3D and the Restore 4D both had about 76% spectacle independence. That means never wear glasses. The Crystalens study, the FDA data from the original Crystalens, AT45, 27% never wear glasses. Okay, so we've come a long way. Satisfaction, this is the goal, patient satisfaction. And the way this question is asked in most studies is, would you have this again? So if you say, yes, I'd have that again, that means you were probably pretty satisfied with it. If you say no, you probably weren't. And so if you look at the Technis multifocal there at 1 year, would you have the same lens again? Yes, 94.6%. It's interesting, it's actually higher than the satisfaction with the monofocal control lens, which was 89.6% at 1 year. So we can achieve satisfaction. Now, in my mind, there are several drivers of satisfaction, or areas for the surgeon to concentrate on to create that phenomenon known as the happy patient. And actually, the first of those is understanding what the patient wants. If we don't ever ask, what do you want, it's going to be pretty hard to satisfy that desire. And then knowing about the available lenses, what the products are, what they can do, is very important, so we can offer the right product to the right person. And then being able to communicate what reasonable expectations are. No matter what you buy, no matter what you want, if you don't understand what it can actually do, you may have unrealistic expectations, and that's a killer for satisfaction because you'll never meet unrealistic expectations, and that's true for anything in life. So we have to be able to communicate those. Finally then, accurate preoperative measurements are key because to select the right power of implant to achieve spectacle independence on the technical side is the single most important thing we can do to get that person out of glasses. And then of course having complication-free surgery, very important. Well here, today what our main area of interest is accurate preoperative measurements. So let's look at some information. This is from a year ago from the David Leeming survey, so it's a little bit old, but it's interesting to look at. All ASCRS members in the US were asked the question, what do I use for my A scan? And a 9.4% applanation, 17% immersion ultrasound, and then about 74% PCI or IOL master. So this is interesting because really we know that immersion and IOL master are fairly consistent in terms of the axial length measurement, but applanation really is not as accurate because of that corneal indentation, the shortening of the axial length. It requires a lot of skill to get it right, and it's more inaccurate. So really there's a range here, but most surgeons are using the latest technology. And then for calculating IOL power for keratometry, it's interesting to see that about 25% use manual Ks. You know, if you look at the Alcon toric IOL study, it's interesting because they used manual keratometry in that study, and you know they have very good results for toric IOL placement using manual Ks, but it was highly operator dependent. You really need a skilled technician to make manual keratometry work. And in that study, they sent trainers to all the sites. They had rigorous training protocols, and they made sure that everyone knew how to do it. Now, in our offices, we may have one tech, maybe two, who have that level of skill with manual keratometry. What happens when one of them is out on vacation and the other one is sick and you need measurements? You know, you're not going to get your manual Ks. Now, automated keratometry is really not nearly as precise as manual, and why is that? It's still using the simple 4 points of alignment, but there's no exclusion. So with manual Ks, when your skilled tech looks at that cornea and says, you know, it looks dry, I'm not getting good crisp Myers, I don't believe this, I'm going to repeat it, I'm going to play with it, that's the kind of thing you need to make that accurate. With autokeratometry, the machine doesn't know if that eye is dry or what's going on, it just gives you an output. Same thing with the IOL master, which actually uses automated keratometry. Some people have the mistaken belief that IOL master is actually using partial coherence interferometry to measure keratometry, and it is not. It's simply using automated keratometry. So it has the same issues. Topography is a little bit better because at least with topography you get a lot more points, and you can get an idea of the quality of the scan, if it's got blank spaces, if it's broken up, if it doesn't look like regular astigmatism. You kind of have a criteria there for throwing it out. But manual Ks actually, it turns out, are probably the most accurate with a skilled operator of these methods. For toric IOL, about 1/3 use manual. And finally, when you get all this data, you know, what do you plug it into? That's very important, because even if you have the best biometry, if you use an old formula that's no longer, you know, considered state-of-the-art, the result is going to be less than stellar. And it's amazing, you know, how many people, to me, 11.5 using the SRK2, you know, second generation formula, that's like ancient history. You know, SRKT, Holiday 1, these are third generation formulas. They're a little bit better, but they're not nearly as good as the Holiday 2 or the Hygus. Why don't more people use the Holiday 2? It's proprietary, you have to pay a little bit of money to get it. It's a couple of $1,000s. Compared to the cost of an IOL master, it's really not very much. And the software that you get with the Holiday 2 allows you to do your own regression analysis, personalize your surgeon factor, and improve your results over time. So for what you pay, it's really not very expensive, especially since you just paid $27,000 or something like that for your IOL master, and now you're going to take that piece of data that you paid so much to get and plug it into a formula that destroys any chance of utilizing the improved accuracy of the measurement. It just doesn't make sense to me. We did a study several years ago now comparing immersion A-scan with partial coherence interferometry just on axial length, and there's actually a very tight correlation, which is nice. So immersion is good for axial length, but the thing is it only gives you axial length. There's just one measurement. Well, you're also getting ACD and lens thickness, but only those measurements. You're not getting anything about keratometry or other features of the eye with immersion. So it's good for what it does, but it's limited in scope. These were the results we demonstrated in that study, and it's pretty good. It's about 94% within plus or minus a half diopter of emetropia. But the other part of that is that we're using topography for the Ks. We're using simulated keratometry for the Ks and the Holiday 2 formula for the calculation. So those are very important pieces there. So new on the horizon, and the reason we're all here at the Hog Strite booth today, is a new development in the field, which is another way of measuring biometry and keratometry, and it's been documented now in several publications using optical low coherence reflectometry. Basically, this is an 820 nanometer interferometry which performs simultaneous measurements on the visual axis. and this is the lens star that we're discussing. So in one touch and about 30 seconds without contact, this gives us the keratometry based on 32 markers. So it's not automated keratometry just using 4 points. 32 markers in 2 rings. It's also giving us the white to white. That's important if you're using a latest generation IOL calculation formula, because of course the great unknown in lens surgery is the effective lens position. If we knew absolutely where that lens was going to be at the end of the day, we'd get perfect results, but we don't. And so we use a number of measurements to give us an idea based on experience where that lens position will be. And white to white is one of those measurements because it gives an idea of the size of the anterior segment. Corneal pachymetry, important for post-LASIK eyes, for example. Anterior chamber depth, one of the most critical measurements because of course that correlates highly with lens position. Lens thickness, something we could not get from the IOL master, had to use immersion to get. Also another measurement of the size of the anterior chamber, size of the lens, and therefore where that lens position will finally be. Pupillometry, something we don't get at all with any of these other technologies, and very useful when we're talking about multifocal lenses. Axial length, of course, the queen of all biometry measurements. Eccentricity of the visual axis, something we haven't talked a lot about before, but angle kappa, angle lambda can be important with multifocal intraocular lenses. And finally, a retinal thickness measurement. So we're getting quite a lot of data out of one touch and 30 seconds. And now we've got a lot of data, a lot of publications showing how well this works. For example, here's one published in the British Journal of Ophthalmology last year. And we can look at correlations between lens star and IOL master, lens star and ultrasound, lens star and OCT, to get an idea of where this fits in terms of precision and accuracy with all of these different publications or different modalities. So here we've got, for example, the mean corneal thickness. Here we've got the anterior chamber depth. You can see that most of these measurements are very closely correlated. Mean axial length, again, very closely correlated. Here's another paper. This I took while it was still in press. It's now published in ophthalmology. Here's a comparison of axial length in a bland Altman plot. You can see very high correlation, again, between IOL master and lens star. Yet another publication from the BJO looking at anterior chamber depth. Superb correlation except for very shallow anterior chamber depths, which is something we're studying currently. And finally, I want to talk a little bit about the really tough problem that we have in refractive lens surgery, which is patients who already had surgery, patients who have had LASIK or PRK or radial keratotomy. How are we going to deal with these patients? What's the best method to calculate the power of IOL for those eyes? This was a paper we published several years ago about post-RK eyes using our current technique, using the Holiday effective refractive power from the ISIS topographer. We were actually able to achieve pretty good results with about 80% within plus or minus a half diopter of target. Still, as you can see, we had some outliers, minus 150 up to plus 150. Those are really not acceptable results, and those people will need enhancement procedures. We'd like to eliminate that. We want to look at outcomes analysis using this new technology in these short eyes, which are also tough, and especially in the eyes which have had a history of excimer laser refractive keratectomy or LASIK. Also, we're looking forward to linking directly the lens star with the Holiday IOL consultant to avoid that step, which has been a real nuisance all the time with the IOL master, because we have to have a separate step of data entry in which more errors can occur. When we can link lens star directly to IOL consultant, and then eventually also, once we get the other vendors to agree, into our electronic medical record systems, then we'll really have eliminated a lot of error and a lot of paperwork, a lot of typing on the part of our technicians to make all these things not only really effective, but also extraordinarily efficient. So thanks very much for your attention, and I'd be happy to answer any questions.